remember, what relationship the broad ligament and the ovary have. The ovary can basically be in a lot of different places, right? Where can it not be? Yeah, for sure. And the broad ligament also prevents it from being anterior to what? Hmm? The uterus. Wow. Was that you, Carmen?
Yeah.
Okay. I had no idea. It's like a disembodied voice. Is that you, God? Yeah, so, yeah, it can't be anterior to the uterus, but where can it be? Okay, so describe some locations. All right, we know the one that's in all the diagrams. Lateral, right? Where else?
Posterior.
Posterior, it could be posterior to the uterus. Yeah, so you may put your transducer down, and you may see a hypoechoic, like this is midline, right? And you might see a hypoechoic structure with follicles with little anechoic, cystic-looking structures on it, right? That's totally possible. Yes, ma'am.
So when you're saying they could be in these different locations, are they in these multiple or do they develop and kind of stay in those locations, or are they changing locations?
So they can certainly change locations. A lot of times that's gonna be due to pregnancy or possibly trauma. Pregnancy, yeah, it's kind of a form of trauma, right? But those ligaments, I was kind of joking as I described some of them as hammocks, but I mean, like, they get kind of stretched, and especially after multiple pregnancies, those ovaries can be moved around. What are the ovarian ligaments? Stu?
Suspensory.
And ovarian?
Ligament of ovary.
Yeah, ovarian or ligament of the ovary, yeah. Yeah, so those in particular are gonna relate more to the location of the ovary. But yeah, they can get stretched around and yeah, some people that, it just starts out that way, right? It's not to say that everybody starts out like nice and lateral, like, I mean, that could just be someone's anatomy, right? Okay, so we said lateral, we said posterior, what else?
Inferior.
Inferior, I suppose is a possibility, not very likely though. I mean, it's, yeah. What else? Mm-hmm. Mm-hmm. So if the ovary is posterior to the uterus, is it within the adnexa?
No.
Oh,
Who says yes? Okay, all right, so Dulce says yes, who says no? Taya sheepishly says yes, Savannah has joined her. All right, explain yourselves. Why do you think that the answer is yes or no?
I say yes, just because based on the lectures, it specifically says like for a region, and it doesn't really say if it's like in or out, it just says like in this region, so that's what I think yes, but I don't know.
Okay, all right. What is your reasoning, Taya and or Savannah?
Because it's the region lateral to the uterus.
Okay, yeah. So, yeah, by definition, right, and this could be one of those, instances where, like, on a TR, it's ultimately it's not super important, but we do want you to understand, right, like, we do want you to be thinking about where is the ovary, right? If you were to, or a sonographer in the field were to say it's, in the left and next to posterior to the uterus, probably no one is gonna like raise a fit, but, we do want you to understand, like, that's not a typical location, not to say that there's anything abnormal about it, but you definitely wanna inform, the radiologist. And why would that be useful, particularly on subsequent ultrasound examinations or sonograms?
To locate it.
Right? You'll get to understand this as you scan, like ovaries, because of their variable location, like it really helps to know where to look. If you know where to look, then, as you guys start scanning each other, like, oh, yeah, that's right, your ovary is way superior to, right? So it saves time. So that, it's a way to make a paper trail for, yourself or your fellow sonographers in the future. And then, that way the ovaries are not mistaken for pathology. So that type of thing. Can the ovaries exist superior to the uterus?
Yes.
Yeah, they can. So these are all things to remember as you go into next semester, right? I'm teaching you normal right now. We will talk about pathology next semester, but it's towards the end of the semester. And right now, things have kind of matched up. We tried to make them match up, like what you're talking about in here, match up within there. Next semester, that's not going to be the case, right? You're going to continue to scan and learn new scans, but that's all still going to be normal. And here, we're going to specifically be going over pathology. So things aren't going to match up anymore. So I do want you to take this information with you as you move into next semester. The serosa, or the serosa is the actual peritoneal broad ligament covering the uterus. The uterus also has a perimetrium, basically an outer layer. I wouldn't call it like a capsule, but it is an outer layer of the uterus. And then we have myometrium, cervix. They're really the same thing. They're both myometrium. Myometrium meaning muscle of the uterus, right? Muscle of the uterus. Cervix is still part of the uterus and it's still muscle, but it does look different. And we'll talk about the ways that it looks different. That myometrium should be homogeneous, more of a mid-level gray compared to other structures. The serosa and perimetrium are going to be more echogenic. So, we did kind of mention this before. What's the difference between these two images?
What type of transducer?
So, depending on the position of the uterus, we talked about uterine positions last week as well. Depending on the position of the uterus, can you see why endovaginal scanning is going to be much more valuable in terms of the uterus itself than transabdominal, right? Transabdominal is like getting an overview, and there are times where, depending on the position of the uterus or the ovaries, transabdominal is going to be the way to go, because endovaginal, what happens with higher resolution? How does that affect the physics of your being? Higher resolution equals
Shallow superficial, can't go deep.
Okay, yeah, so it means less penetration, right? Higher resolution, less penetration. So if the ovaries are located superior to the uterus, if the uterus itself is retroverted, retroflexed, then yeah, maybe we won't see very well with endovaginal scanning. So transabdominal will be important in that instance. But overall, in both modalities, you know, we should be seeing this more mid-level grade. This may have more to do with technical settings.
It's like the resolution on that one though looks a little crazy with the, like there's lots of, like on the outer edges that, I don't know how to say it, but the speckles are look all elongated.
Like this,
Yeah.
talking about that?
Mm-hmm. Is that just, do they have worse resolution? Do they have a similar resolution to what we use?
Do the, are you asking if the
That-
endovaginal
Transducer is,
transducer? So typically it's, I wanna say like around a 7.5, frequency.
okay.
So higher frequency than the curvilinear probe. Yeah, 7 point, that's a good
I
question.
think there was also something to do with, when it's forming the beam, the more steering it has to do towards the edges.
Oh, yeah, because
Yeah.
that's
Oh,
longer.
Yeah,
It's in the, it's actually, that's what, it's in the notes actually, 7.5 and higher. So yeah, you can get, much better resolution.
Hmm.
But obviously you can also lower it if what you're looking at is either sonographically dense or just deeper in general, or farther away from the transducer. So, in both of these, images, we're able to appreciate the different portions of the uterus. So here we have the fundus, body, and then this area that looks a little bit different, and for some reason that they didn't include in the overall uterine length measurement, that this particular sonographer did. This area is the cervix. That being said, with the uterus, it's one of the few organs that we take both the length and the AP, or the thickness, in the long plane, in its long plane. Why do you think that is? What's the most accurate beam angle or angle of approach for taking a measurement?
Perpendicular?
Yeah, it's always gonna be 90 degrees. So if you're transabdominal and you turn transverse to get the width, what's possible that you're doing if you're trying to measure the AP, the thickness?
You measure it at an angle instead of the,
Yeah, you might be doing this, you might be doing this. It's hard to tell. It's hard to tell because of the way the position of the uterus. Also, it can be harder to tell, like the version inflection on the uterus from a transverse approach, but it's fairly easy to recognize in long. So for that reason, it's the AP measurement is taken at its widest point, right? The largest dimension, anteroposterior. And then typically what we do is we follow the endometrium, right? We go, like visually. Our machines don't do this, and this one doesn't either. There's a lot of machines, there are a lot of machines. Wait, do our machines do this? Do we have little dotted lines in between the calipers on our machines?
dash.
Oh, we do.
Dashes.
They're
Okay, good.
dash.
Dashes, yeah. Okay, good. This one, it doesn't do that, right, but it is helpful, oh, it doesn't do that on Doppler, that's right. Yeah, so it is helpful when you have that type of thing, so you can follow a line, right? So generally speaking, we'll measure the length from the fundus all the way